So, good morning, everyone. We love to welcome you to this session, which is a joint session between BEC and WIST, dedicated to the same cause, and that is increasing the amount of stroke treatments that can be done. It is about learning from each other, about multi-speciality approach to stroke treatment, so that we can provide the huge gap that currently exists in stroke training. What we are going to do during this session is we are going to talk about the latest developments in stroke, but we're going to start quickly about what is the need. First of all, I'm very pleased to have my fellow panelists and moderators here. We have Professor Klaus Mathias, who is joining us, and then we have Dr. Ivan Vukasinovic, Dr. Deniz, Bilja, Dr. Nurfet, Alioski, and we'll be shortly joined by Dr. Piotr Musialek as well. Anna, please, would you join us and give us a quick overview about the gap in stroke treatment? Very quick question. Wait, I'll just get out. I should be on the same one. How many of you are involved in stroke treatment? Okay. Okay, so basically everyone. And from your background, how many of you are cardiologists, interventional radiologists? Also both, yes. And perfect. Vascular surgeon? No, vascular surgeon, oh, yes. And anesthesia? Okay. Good. Well, Anna, all handing over to you. Thank you.
Thank you very much, and thank you for Professor Piotr invitation and highlighting the importance of stroke, which is still a global problem. It is still a second most common cause of death worldwide, and the third most common cause of the worldwide disability. And people like Graham, who was shown on the video, they are affected day by day by this disease. And as you can see, it's not the disease of the old people anymore. More than half of the stroke happens for people under 70 years old. And it was many years ago. So Iris did her first thrombectomy in 2006. The first BEC, the first training in endovascular therapy here was set up in 2008. And we got our evidence in 2015. This is also the year that the WIST was set up to carry on the mission, to train more people to deliver this life-saving treatment to patients. And there are vast inequalities across the world. This is the empty glass study, which was looking at the availability of mechanical thrombectomy worldwide. And it's sad to see how not a lot of green is visible on this map. Moreover, there are huge disparities in the urban and the rural environment. And as you can see in Bulgaria, with the moderate amount of the rurality, the access to the mechanical thrombectomy is not much. It's less than 1% of all eligible patients. So there is still some work to be done. However, I'm looking forward to listening to the talk about the local protocols in Sofia and learning how they can be scaled up for the whole country. And there are multiple barriers to why we are not having this 100% availability of the treatment. And the WIST was created to focus on two of them, to increase the number of the people trained and to increase the number of safe thrombectomy centers. And with that, I would like to ask Iris and Professor Mathias to carry on.
Thank you very much. Thank you very much for this short introduction in that field, and we will go on. And it's now a pleasure for me to have Iris again on the podium, and you will talk about, the mission of WIST, including credentialing, not only training, but at the end we are also credentialing the trainees.
Thank you very much. I will briefly talk about what WIST is. WIST is a not-for-profit organization established back in 2015 when the randomized evidence came out by a group of specialists from all fields, including specialities from anesthesia, neurosurgery, neuroradiology, cardiology, interventional radiology, and anyone involved in the interventional treatment of stroke, to really come up with a plan on how can we increase multispeciality training. The guidelines for the World Federation for Interventional Stroke Treatment are the first guidelines that actually focused not on time-based competency acquisition, but on skills-based competency acquisition. So, for example, an interventionalist who has done 200 carotid stents will already have that skill. That's something that they do not need to acquire again. A radiologist will have the skill of interpreting the images and knowing the early signs of stroke. So it is about making use of what skills are already available and providing targeted treatment rather than a general curriculum for all. And for that, the other difference is that we are using high-fidelity simulators for the training as well as the perfused human cadaveric model. There are two accreditations. There's the accreditation for the operator, which is valid for life, but you can be the best operator in the world, but it takes you 3 hours until in your center you can get the patient onto the table. So your patient will not have the best outcome, so then there's also a center accreditation. Now, in short, what you need is 50 carotid artery stent procedures, either done yourself or done under supervision on a simulator or on the cadaver, 25 stroke procedures and 60 diagnostic angios, complications training, competency and risk management assessment, including imaging, clinical assessment of the patient, and then we also recommend a hospitalization in a large volume center. For the imaging, we are now often using AI tools where basically you learn how to interpret the scans and you get the result afterwards. So you do not need someone sitting next to you, physically sitting next to you, but you have a repertoire of images where you have to score them or you have to interpret them, and then the AI tool gives you the answer afterwards. And very interesting, even for a diagnostic neuroradiologists, it takes over 50 scans to become more sure and have a more stable state at interpreting early signs of stroke. I think it is very important, even if AI software tools are available now, that we are able to interpret the images ourselves as the operator. As for the procedural knowledge, a lot of the procedural knowledge is acquired on the simulators, and where you can also practice complications like a perforation in a safe environment. And in addition, we have the cadaveric model where you can do real devices, and you can also use flushing, and which is a very important skill during the interventions. Now, how does it work practically? Practically, usually there is a site visit, a hospitation, where one looks what are the individual needs of the hospital. So, for example, in the hospital I'm currently in, we had 5 interventional radiologists who have now all been trained to perform this treatment. And we saw that the hospital pathway was that patients go to the A&E department. And that was on the other side of the hospital, so a huge delay with that. So the first thing we did is we are bypassing A&E. By the way, one of the biggest time savings you can have in stroke, where per 9 minutes delay, there's a 1% lesser chance of a good outcome. So we are now bypassing A&E, and that saved us 41 minutes. Where the patient is met directly in the CT scanner and by the interventional team and by the stroke team. Most importantly, the physical on-site support and the proctoring with ongoing audit and feedback. You need to see how your data is. You need to see where there are weaknesses and where there's room for improvement, and also help in setting up the imaging protocols, for example, fast MR protocols, also the paperwork that is involved with it. And let's not forget the main part, the educational meetings that we're doing, like here in BEC, like in ICA Stroke, where we are really joining a community of like-minded friends who will support each other in the setup of new thrombectomy centers. Thank you very much.
Are there any questions? The audience? Everything clear? I have not expected something else because I know that Iris can speak very clearly sometimes a little bit fast. So those who are not so familiar with English must be very concentrated.
So we're probably another thing to say. So we're also for the honor of BEC, we're also providing a separate training course, and you will have a BEC code where it will be possible for anyone who's interested in really acquiring the skills and getting training with the real devices to becoming and to us, and to use our human cadaveric model and to try and get more training in the skills that you're still missing. So that is a possibility, and if that is the case, either approach Michelle or myself, and we will give, or Ivo, and you will get more information about that. And we will go on to the next talk.
Yes. So the next is